Hi, my name is Serena Chen. I'm the Director of Reproductive Medicine here at St. Barnabas Medical Center, and I want to talk with you about a topic I call the end of sex for human reproduction. So I'm not saying the end of sex, forever, because sex is fun. We're talking about the end of sex for human reproduction, the implications of a lot of this new genetic and reproductive technology that we do every day that you might not know about, but as a healthcare provider and as a citizen of the world, we feel is so important for you to know and understand what's going on, because this is going to impact the future, possibly the future of the human race and future generations. So the concept is really laid out really nicely by Hank Greeley, who wrote a book called The End of Sex. You could get it on Amazon for about $15. He's a professor at Stanford of law, and he does, in really nice layman terms, talk about different technologies like IVF and stem cell technology and genetic testing and modification in easy to understand terms. So I highly recommend the book. It goes into a lot of detail about these concepts, and we're going to go through some of those today. I got really interested in this when I was asked to do a talk or a discussion at the 92nd Street Y with a gentleman named Jamie Metzl, who is a technology futurist, and novelist Gina Bartesi, who's a tech startup person in biotech, and myself and Professor Greeley, who wrote the book, The End of Sex. So this is Jamie Metzl. He did come and do Schwartz rounds with us this year, and just came out with a new book called Hacking Darwin. That is the second book I'm recommending, really easy to read. Also, a lot of stuff in layman's terms, but does tell a very compelling story about how this technology may really impact our future and some of the issues that we have to think about. So what are the basics? The basics are that right now, just having sex to reproduce, if we look at it from the point of view of all this new technology, it could be seen as a little bit like Russian roulette, because you're just taking what you get. A sperm and egg get together, embryo implants, and then you see what happens. Whereas the future is almost here now, where we can control a lot of those events and use the technology to not only help people with infertility, but also help fertile people have healthier pregnancies, prevent genetic disease, lower the risk for miscarriage, and possibly even improve health and wellness, and possibly get to the point of things like designer babies. So, we're heading there right now, and it obviously brings up a lot of important questions about how should this technology be used, how do we feel about it, and that eternal question of just because we can, should we? And that's why I'm talking with you here today, because I really want you to understand these issues and be part of the dialogue as a healthcare provider. So, very simple concept right now to reproduce. We have a sperm, an egg, a uterus, and then we make a baby. I'm not really much of an artist, so this is not drawn to scale, but you get the idea, and hopefully end up with a cute, healthy baby. And when we talk about these technologies, IVF technology and assisted reproduction, we're seeing that the process of in vitro fertilization used to be very, very difficult and expensive and inefficient, and is becoming easier and easier. And the process of genetic analysis used to be very, very difficult, lengthy, and super expensive, and now is becoming much cheaper and easier and much more accessible. And stem cell technology now will start to play a role, because at some point we will be able to take a few skin cells or spit in a cup and take those cells and actually just deprogram them and make them into gametes like sperm and eggs. And that will remove a lot of the inefficiency we face right now. So if we can create large numbers of sperm and eggs, we can make routine reproduction into a highly technical process where we can get a lot of control and a lot of say and a lot of choice. So right now, our current IVF barriers are, it's a lot of work. So most people that are doing IVF now, really, they have something wrong. They have infertility. They're not able to conceive on their own, or perhaps they are both carry the sickle cell trait and don't want to have a child with sickle cell disease. So there's an issue we're addressing, and IVF is often not covered, and it takes a lot of time. You have to inject hormones, and we're only getting a few eggs at a time. And so what we're facing is very much a numbers game. So IVF, basically, you're taking some fertility drugs. We need more than one egg. Most eggs and most sperm are no good. So you need, the more eggs you get, the more sperm we get, the better embryos we get. The more embryos we get, the more likely we are to get a healthy embryo that can actually make a baby. So we are taking the usual site of fertilization, normally in the fallopian tube, and taking that process out and putting it in the lab. So IVF just means in vitro fertilization, fertilization outside of the body. So it's a process where you stimulate the ovaries to make a bunch of eggs, as many as you can. The typical number is 13. We put it together with the sperm, and we make the embryos. We let them incubate and grow, and then we select the best embryo for transfer. This is an invasive procedure. It's minimally invasive. It's a needle-guided, it's an ultrasound-guided needle aspiration of the ovaries. Literally a 10-minute procedure. It's done as an outpatient. The patient usually just doesn't get intubated, maybe a little laryngeal airway, a mask, some propofol, some fentanyl, and 10 minutes later all the eggs are out. They go home, not much discomfort. It does take about 2 weeks to get to that stage, 2 weeks of injections every day to get to that stage of the egg retrieval. And most people tolerate that well, but it does require a lot of monitoring and things like that. So it is a lot of work for the patient to get to that point. Now, we retrieve a lot of eggs, but not all the eggs are mature, and not all the eggs will fertilize. Right now, when we want to do genetic testing on our embryos, we actually do a procedure called ICSI, where we inject the sperm into the egg. And this is also a procedure that's really helpful when somebody has male factor infertility. So when the sperm count is really low, sperm is not working well, ICSI can make somebody with severe male factor infertility just as fertile as somebody with a normal sperm count. When we're talking about genetic technology, we use this technology a lot to make sure that there aren't a lot of other sperm around. So if you look at this picture, this is on the left is an egg that has not gone through ICSI. It's just been dropped into a little droplet of sperm. And that's how we do typical IVF when we don't do assisted fertilization. So you can see that all the sperm are just stuck all over the egg. And those are all the loser sperm. All the loser sperm get their little faces stuck to the window because they didn't make it in. But they stick around. So you see, look at the second picture on the right, all those little bumps all over that embryo. That's a day 5 embryo. So it's 5 days after the sperm and the egg have gotten together. The sperm that didn't make it, they're all still stuck all over the embryo. And so that's why when we do genetic testing, where we actually have to pull those cells out, so we actually dive through that shell on the outside and pull 5 to 10 cells out from an embryo that has over 100 cells, you can see all those little sperm around. You could possibly get DNA contamination of your test results. So that's the reason why we often do ICSI, because we have just one sperm, one egg, and we know the results will be clean. Once we get a good embryo, this is how we put it back. It's very similar to a pap smear. It's very easy. It's done while the patient is awake. It's not a difficult procedure. We do use ultrasound guidance just to know where the placement of the embryo is. But again, that procedure, a very easy procedure done while the patient is awake. So when you look at embryo development, This picture shows development from the egg to the zygote, which is that first picture where you see the two little circles in the middle. That's showing the male pronucleus and the female pronucleus, and the egg is fertilized. Then the next picture shows 2 cells. It started to divide. The next picture shows 4 cells. That's kind of like, those 2 pictures are like a 2-day-old embryo. The next picture is more like an 8-cell embryo. That's the 4th picture in, and that's about 3 days old. And then the next picture where you see that there's a bunch of cells and a cavity in the middle, that's called a blastocyst. And that embryo is about 5 days old, and that's when we can usually do the embryo biopsy. And the chunk of cells on the right, you see with the yellow, that is the inner cell mass. That's where the actual baby is. And the cells on the outside of that ball are the trophectoderm. That's going to become the placenta, and we can biopsy the trophectoderm without harming the embryo. And so this shows an embryo biopsy, and where we actually use, this is under a micromanipulator. This is magnified hundreds of times. This embryo would not be able to be seen with a naked eye. And this is a little skinny glass pipette tip that's been fire polished, so it's really smooth. And they use very gentle suction to, after hitting the outside of the embryo with a little laser, just to break open the shell, then use this gentle suction to gently tease out some of the cells from the trophectoderm. And we have a special device where your hands are attached to these micromanipulators that translate your gross movements into micron movements. So that's how we're able to do this procedure. But it is like microsurgery, and if you don't do it well, you can kill the embryo. So it is important to have training and experience in this procedure and to do it well. And some places do it well and some places don't, which is one of the reasons why it's not everybody is doing it yet. But this is coming down the pike. More and more people will be doing it, and maybe we'll be seeing robotics and things like that coming into play. So easy IVF. If we can take this process that you just saw, that I just went through, and make it a lot easier, then maybe using some of this technology to help healthy people have healthier babies, it might start to get utilized more often. In fact, healthy couples have a 1 in 4 chance on average, 25% chance on average, of any pregnancy ending in a miscarriage. And miscarriages can be very devastating and can create morbidity and complications. And if we could get rid of miscarriages is easily, without too much trouble, we might start to do that. So you can see that if we could take this complicated process right now and make it a lot easier, that then the barriers would start to fall, and things like preventing miscarriage might become more of a priority even for healthy people. So right now, this genetic testing is very expensive, and it used to be very difficult to do genetic testing. And you can see that dramatic improvements in genetic diagnosis have taken this from a multi-million-dollar project now down to thousands. And so we are doing this for people who are at high risk for genetic disease. If we can make this even cheaper and easier to make sure that every pregnancy has a normal number of chromosomes, we could eliminate miscarriage. And the easier and cheaper we make this, the more accessible it will be. We can start to go even further, because now we're starting to see things, not just Mendelian traits, not just chromosomal things, but now we're starting to see that we are getting a better understanding of multigenic traits like cardiac disease, like height, like intelligence, things like that. Right now, we're not able to do this because with only 13 eggs, on average, I usually end up with maybe 2 embryos, and maybe only one of those embryos or 0 of those embryos will actually have normal chromosomes. So it's very hard to get a chromosomally normal embryo right now. And some couples struggle for maybe 1, 2, 3, 4 IVF cycles before they can even get one normal embryo. And that's not so abnormal. That's just the inefficiency of Mother Nature today. But what if we could make 1,000 embryos really easily? What if we could make 10,000 embryos really easily? Then you could check for more things besides just chromosomes. Then you can check for single gene diseases. Then you could check for things like height and intelligence. And, so we are moving towards that, and that's where stem cell technology might make a huge difference. I almost feel a little bit relieved that we actually can't do this right now, because I'm not sure how we should use this information and this technology. Should we really be selecting for things like intelligence? I personally, I don't know if you can see this and you've never met me, but I'm like barely 5 feet. And my mom, I know if this was available to my mom before I was conceived, she would not have chosen the short, loud embryo. She would have chosen the tall, quiet embryo. So I don't think I would even be here. So I definitely have mixed feelings about this technology. And if we're selecting 152 genes for intelligence, and you're skewing something in a way that doesn't happen so often in Mother Nature, and knowing how complicated genes are, that most genes are multitaskers and don't do just one thing. If you're selecting a particular group of genes, what other systems are you affecting? Yeah, you're selecting a very intelligent embryo, but how are you affecting the other systems? Is it possible that some of these genes are related to the liver or to the bones or to other systems that could be really critical for health or normal functioning? We don't really understand how those things work yet. And we're on the cusp of being able to essentially start to make designer babies. So that's the question. What should we do? And the future is really right now. So this is not so Brave New Worldish. It sounds a little Brave New Worldish, but it really is not. Today, I make test tube babies every day. I select embryos with normal chromosomes, and that includes the sex chromosomes. And a lot of people want to be able to have a boy first or a girl first, or have the girl after the boy, or have the boy after the girl. Or some people they don't feel comfortable with girls. They only want boys. Some people don't feel comfortable with boys. They only want girls. We've seen the process of sex selection in other areas, like in China and India. Much less sophisticated technology, especially like things like abortion and infanticide. But they've done it. They've been doing sex selection for many years and have created tremendous social issues. In fact, the WHO thinks that the very skewed sex ratio in India possibly is related to like the rising tide of violence against women. And they've shown a correlation with changing sex ratio and violence against women. So there's a lot of implications to doing even something as simple as, I'd like a boy or a girl. In the United States, we see its vast majority is family balancing and not sex bias. And so, we do it for our patients, knowing that, telling a lot of our patients, especially our infertility patients, it's going to be hard just to get one normal embryo. So, we could think about that, but you might only have one embryo, and it might not be that sex you prefer. And then what are we doing? Are we going to help you get pregnant with that embryo? So we're doing this right now. We're also doing things like preventing cystic fibrosis, preventing sickle cell disease. So we are doing a good job with Mendelian disorders. But when you start to get into multigenic disorders, that's starting now. And so we have to remember these things can be complicated. And what are the implications of these kinds of choices? Because these kinds of choices are going to be more and more available to us every day. And how do we as healthcare providers, how do we counsel our patients? How do we try to take part in the dialogue? How do we talk with regulatory bodies about what we think is reasonable and what should be done. So we do think it's reasonable to prevent miscarriage right now, and prevent things like Tay-Sachs and spinal muscular atrophy. But what about deafness? So non-syndromic hearing loss is something that we can prevent. But if you were living in the deaf community, you might actually say, doctor, I don't know, if we have a child that's hearing, I don't think they will fit into our community. They would feel like an outcast. We would not know exactly how to raise them. We want you to transfer the deaf embryo. How do we feel about stuff like that? We are having to face those kinds of things. A child with severe thalassemia wants to have a sibling to be a stem cell donor. It is obviously that child can't consent to that. What is that something? How do we feel about that? We've been doing cases like that. We have done cases like that. Family history of Huntington's. The husband's dad, died at 42. The husband's in his 30s. He does not want to be tested. He wants you to test him. He doesn't want you to tell him the results. He wants you to transfer an embryo that does not have Huntington's disease. You can do this. How do you feel about that? How does that feel to you? It brings up a lot of different questions. So, when we're able to select a blue-eyed embryo over a brown-eyed embryo, a tall embryo over a short embryo, a smart embryo over a less smart embryo, what are we going to do about that? How are we going to use this technology? We don't really know about that yet. But we can, those are all things that we need to think about. And obviously, this whole thing can be really controversial. Designer babies is essentially what we're talking about. How do you feel about designer babies? I'm sure your opinion might be different from my opinion, and that's okay. But how are we going to handle this technology that really potentially has significant implications? And do we really understand what all the implications are? Not necessarily just about choosing a cute baby. If we're really strongly doing genetic selection, do we really understand what the other manifestations are, and what kind of studies do we need to do beforehand? What kind of regulation? Who should be allowed to do it? Who should have access to this technology? All of those kinds of things are big questions that we have now. So making a baby today is getting more and more complicated. I included this slide. This is like a situation where you could have the egg and the sperm both coming from another source other than the parent. So you have on the left side the two IPs, they're the intended parents, and they have an REI doctor, that would be me, reproductive endocrinology. If you're using gametes from another source other than yourself, usually we have a psychologist involved to discuss the implications of that. We're having an issue with donor egg and donor sperm. Traditionally, that tends to be anonymous, but now today, with everybody doing 23andMe and Ancestry.com, now a lot of people are finding out that their dad is not their dad, or the person they thought there was their dad is not their dad, and we're dealing with a lot of those issues. And now we have to realize that donors no longer be fully anonymous, and some people, can't carry a baby safely, and so we often can get another party involved, somebody who will actually carry the baby. And there is technology now where we can actually gestate a sheep for part of pregnancy in a fancy Ziploc bag. This has been done at University of Pennsylvania. And so I think, at some point we are going to be able to, grow a human baby in something other than a uterus. And I always feel like this is a good chance for perfect gender equality, because I think the guys should carry for half the time. But I'd stick the, Ziploc bag, put in a nice backpack. They can, carry it for 4.5 months. The wife can carry it for 4.5 months. We just have to worry, hopefully nobody leaves it on the, on the subway, because then the baby would belong to TSA. So a lot of details to work out, but think about that. Like, what are the implications of that? So again, IVF is becoming faster, cheaper, more accessible. Genetic testing, faster, cheaper, more accessible. We thought that genetic modification was maybe 5 to 10 years away, and now we already have a couple Chinese genetically modified babies. Their genes changed by CRISPR already just a few months ago. So we really have to think about those things right now, and things like sex and genetic selection, at least for disease-related purposes, is happening right now and more commonly. So just because we can do all these things, should we? And that, I feel, is a question that affects the entire human race, because theoretically, if we start doing genetic modification or a lot of genetic selection, we are changing the course of our biologic futures. And, you know, that could be a good thing, but I guess it could also be a bad thing too. And that's what I really want you guys to think about. So this is showing, I always think about that Will Smith movie Legend, where they cure cancer. And he's a scientist in this dystopian futuristic movie. They cure cancer, but everybody turns into a monster, and he has to fight all these monsters at night because they like destroy the earth. There's also Sorry to Bother You, which is like more, I don't think it's a widely distributed movie, but I think you can find it on like Amazon or Netflix. Also about genetic modification and the future of like how corporations like Amazon and Google maybe are taking over all our data and our minds, and are also getting involved in biology as well. And we know that Amazon and Google are very interested in that sector. So a lot of interesting stuff to think about. This was the cover of Time magazine just recently. The left is the original version. The right is my version. And again, something very simple and basic, but a lot of big changes happening right now. So I'm really glad you listened to my talk. And I just want, keep it in mind, keep your eyes open, think about it. Don't be silent. I know you have an opinion, you take care of people. Let's talk about it. Let's try to, be open and transparent and accessible and do the right thing. This is our group. All of us here, we have 8 doctors, 7 offices. We're all over New Jersey. Everybody's really nice and friendly. And you want to talk about making babies in a test tube or freezing your eggs or anything, just come and find us. And this is probably one of the easiest way to find me is on social media, on Instagram or Twitter. And I'd love for you to connect with me. And I'm trying to use these platforms to, again, continue this dialogue, and because it's going to reach way beyond just the healthcare sector. We have to talk, with government and the lay population, and so we all have to connect and have a dialogue about it. So, it'd be great if you connect with me. Thank you.